everyone, and welcome to The Edge of Healthcare, lessons from leaders to use right now. Today, I'm fortunate and pleased to bring a guest in, Ron Urwongse, who is from Defacto Health, founder of Defacto Health, but has a pretty well-established career in healthcare, to share with us some of the wisdom and insight he's gained along his journey in healthcare. Ron, welcome.
It's great to be on the show.
Thanks so much for joining us. You know, I like to always start off with a little bit of background with regards to your journey and where you came from, kind of an educational aspect, and then what was the first spark you had as it relates to getting into healthcare?
Yeah, Martin, thanks for asking the question. I have to say I ended up in healthcare almost by accident. I started off my career as a software developer. I wanted to get more onto the business side, so I went to business school at MIT. And while in grad school, I had a chance to work with a lot of really interesting startups. I loved working in these small entrepreneurial environments. Had also some experience with working with large software companies and decided that, gosh, that's not for me. And so, I looked for the most interesting startup that I could find in the Boston area after graduating from MIT. And I found this small company called Vectin Technologies, and that's where I got started. They happened to have a focus on healthcare. They did patient check-in kiosks, infection surveillance software, and medication delivery robots. And I had an opportunity to play product management roles in a lot of those different areas. And that's where I got started.
So you went to undergrad with a purpose to kind of be a software developer. And then in grad school, you got bit a little bit by the healthcare bug, and it completely changed your path and trajectory.
Yeah, I'm attracted to big intractable problems that take years to solve and require collaboration. And I love exploring all the nooks and crannies of a problem space. And that's what I love about healthcare. You can work on a problem for years and make some continuous progress towards a solution.
I was just going to say, if you want an industry with large intractable problems, you have found a home forever in healthcare. That is for sure. One problem in healthcare is the fax machine, but we'll save that for another day. Tell me a little bit about Defacto Health and what problems you're trying to solve there.
I guess to start on the story about Defacto Health, I actually have to go back to my previous employer. So when I worked at CAQH, which was a not-for-profit alliance of health insurers, they focus on provider data and member data and interoperability. And when I was there, I had a chance to learn a lot about provider data and the provider directory problems that payers face. I also had the opportunity to launch an interoperability endpoint directory as the government started mandating API requirements for payers. And that's where I started to get a peek at all of the data that would be available soon enough via those APIs. And I decided, well, gosh, I really need to set off on my own and you start making that data operational, making that data useful. And so that's when I founded Defacto Health with my partner, TJ Theagarage. And we've been integrating with payers' provider directory APIs, which are mandated by CMS. And what we're hoping to accomplish is to assemble the nation's largest data set of healthcare providers and the insurances they accept. And we make that data available to any company that needs to use it for a multitude of use cases across various verticals.
So you mentioned a couple items there that I want to kind of expand on a little bit. So you mentioned, and maybe we get some definitions. So you talked about CAQH. What is CAQH? What do the letters stand for? And what is the main purpose of CAQH?
Yeah, CAQH, it's interesting. It's almost like KSC, where everybody just uses the acronym now. But if I remember correctly, it's the Council for Affordable Quality Healthcare. And
Correct.
They are not-for-profit, and payers get together and they build solutions where collective action is required and no one payer can build it on their own. And so, things like the ProView portal that allows providers to enter their credentialing data and submit it to any payer who needs to get it. That's one thing that they're very well known for.
Well, I think that's It's an interesting point because when people think of healthcare, I think the first thought that pops into their head is the provider-patient interaction. The methodology of care, the provision of care, the care location. Is it at the doctor's office? Is it at the operating room, the hospital? That's what they think of when they think of healthcare. But there's a whole series of healthcare well prior to that interaction. Getting that, as you mentioned, that provider credentialed, making certain that he or she is licensed to perform medicine. And I think that's a facet that not many people realize is fraught with intractable problems and challenges, as you mentioned earlier. And one of the key areas, another definition that I want to pull on, is the term interoperability. Because I've been in healthcare for 35 years. I think I've heard that term just about as long as I've been in healthcare. But I'm very curious for the listeners and viewers, what does interoperability mean? And then what will it allow to happen once achieved?
Yeah. So it's interesting because oftentimes when people, at least nowadays, think about interoperability, it's all been about patient data. So as a patient, can I have access to my data? Can I avoid filling out a paper form on a clipboard before every single appointment that I have with a doctor? Even if it's with the same doctor's practice. So that's often what people think about, interoperability. Can all of my various healthcare providers have access to my data and make the best recommendations and diagnoses relative to that? But, I'd love to broaden the scope of interoperability because, as I mentioned, provider directory APIs also offer this data via interoperable methods. These are FHIR standards-based APIs. HL7 Da Vinci defines the implementation guides for these, just like they do for Blue Button and for some of these patient use cases. But, you mentioned credentialing and licensing. I think you kind of hinted at payer enrollment. Gosh, wouldn't it be great if we could leverage these same interoperability standards to solve for those use cases as well? There's such significant overlap with some of the same data that I'm consuming for provider directory use cases. It's something that, as an industry, we should look into. Every opportunity I have, I encourage companies who are tackling some piece of this problem to see how they can share data with others, avoid any type of keystroke by pre-populating data. I mean, I think that's really the future. There's really no reason we need to hand enter data when we can know it from a source, from a primary source.
Amen. Completely agree with that. And I think it would befuddle, confuse, anger, frustrate most individuals if they recognize behind the scenes how much manual tasks and keystroke data entry that you referenced is occurring upstream from that provider-patient interaction, especially in the year of 2024. I mean, it's amazing to think of that, like you said, physician offices are still handing out a clipboard with information that someone has to hand write, and then that information has to be keyed into a system. I think they're getting better on the clinical side of things, but we aren't getting better at the speed with which society needs it on the administrative side of things. And it's costing, as you know, to the tune of about $500 billion a year of just absolute waste from an administrative data standpoint. And that's the key element there as it relates to interoperability. This is administrative data. This isn't PHI. This isn't claims data. This isn't sensitive HIPAA patient data or anything like that. It's just administrative data, people's names, addresses, phone numbers, NPI numbers. So once interoperability can help that data flow, what are some of the downstream impacts you'd like to see?
It's a great question. And it's one that this is a little bit of I have a dream kind of thought in my head. We need some type of North Star that we can all as an industry agree on, that this is where we want to be. This is where both providers and payers would like to be. Like, wouldn't it be great where a provider just has all of their credential information in one place, and the credential is a credential. You don't have to verify it. Like, wouldn't it be great if it was pre-verified and you could see it and you can just trust it? And wouldn't it be great if a credentialing event could happen within minutes rather than days or weeks or months. You know, it would have so many downstream impacts on mobility of the healthcare workforce. And mobility is important because we have such significant supply constraints. And if we can make the healthcare workforce more mobile and being able to move from one employer to another, or et cetera, or move from one payer to another, then they can migrate to the place where they are most needed. Makes health insurer networks more dynamic. You could create custom on-the-fly networks for an employer that meets the needs of their employees. Like, there's just so many ways this could have downstream impact, and not even talking about all the administrative savings of saving all of those keystrokes that human beings have to take, and you could redeploy that human capital elsewhere on more significant problems like healthcare quality and outcomes.
Yeah, I agree, and I hope it happens on an accelerated timeline. You mentioned workforce mobility as it relates to clinical staff or back office staff, and certainly I think it would provide a amazing boost for clinical provider fatigue, which is much needed because of everything that we've experienced. But for those listening and watching, let's talk a little bit about workforce mobility. In that, over the last 3 to 4 years, we've had a global pandemic, and a lot of folks have now started to work from home and work more remotely. I was actually doing that for 25 to 30 years prior, so it was nothing foreign to me. But what wisdom and lessons from a discipline standpoint and habitual daily routine standpoint would you give someone who this may be their first time ever working remotely and they aren't going into the office 5 days a week? How can your background and share some tips, if you will, on here's some things that you need to do on a daily basis to make certain that your happiness is where it needs to be and your productivity is where it needs to be?
I think, like you, I worked remotely even before the pandemic. I mentioned I was working at Vecna Technologies up in Boston. I actually moved down to the DC area to be closer to my wife's family. And, there was an office there in the DC area, but my team was up in Boston. And, it's incredibly difficult to manage a remote team. You do every other week you can fly up there, and it's not a long flight from DC to Boston, and you can go in for a day or two, and it's not awful. But it's interesting because, like, if a company is all remote, then everybody is on the same playing field, and they can communicate with each other on that same platform or playing field. And if everybody's in the office, then it's easy. But if some people are in the office and some people are remote, then it's incredibly difficult for the remote people to know all of the hallway conversations going on.
Right.
So, I think my suggestion for folks who are getting started in their careers or maybe working remotely for the first time is, you have to kind of harmonize with the rest of the company. Like, if they're mostly in person, you've got to have some FaceTime with them, because you're not going to know everything that's going on being a remote worker. If you're an individual contributor and you want to continue to be an individual, maybe it's fine as long as you have a great relationship with your manager. But if you're managing and you've got to interact across departments, like, you've got to have some face.
Yeah, and I think you're seeing a lot of businesses now recognize that whether it's going to be a quarterly meeting or 1 to 2 days in the office for those people within a certain proximity, they believe that there needs to be some FaceTime, that there needs to be some in-person socialization at an office in a work environment, just to augment some of the remote work. I agree with you. I think you're going to see that play out. There's no rule book or guidebook or instruction manual to navigate this right now, but I definitely think you're going to see that play out. I want to be, before we go into our next segment, I want to go into, you mentioned CMS as it relates to kind of some of the mandates that have come down as associated with provider data. If you could wave a magic wand and get one wish granted by CMS, what would that wish be?
If it's just one, it would be to enforce the rules already on the book. There's some good ones on there. It's been almost 3 years now since the effective date of the first final rule for provider directory APIs. And, unfortunately, there are still some payers not complying. I'm not going to name any names. And the good news is that most payers are complying. They have functional APIs and you're able to query them. But there's still like a tail of payers that either don't have an API yet, or they have an API, but it's not functional enough to answer the most basic question of, does this provider accept my plan? That is the main question members and patients want to answer when they go visit a provider directory, and that those APIs aren't able to answer that question is unfortunate, and it's something that needs to be resolved.
Yeah, and it's interesting too, because we actually don't tolerate that in our personal lives. And I'll give you an example. If you went to a restaurant's website because you were planning a special celebration, and on the website that restaurant had listed 10 different locations, and you found a location near you and you planned a big evening, and then you went to that location physically didn't exist, or that location was closed, no longer open for business, you would never frequent that restaurant, or it would be a very, very long time before you gave that restaurant your business. But in healthcare, these directories on the payers' websites or on the provider websites, members are supposed to navigate them on their own. They're supposed to rely on that information. And oftentimes, and the percentages are alarming on how often that information is incorrect. And that also then has downstream negative impact, because then the member, the patient, if you will, all of us consumers and payers of insurance, they end up calling the payer, and then the call center gets clogged down with very, very mundane questions about, is this this provider in network or out of network? So why do you think payers are resistant to wanting to improve the member experience as it relates to member directory?
I think there's plenty. I was going to say the word blame, but I think responsibility is probably the better word to go around across the payers and providers. And I think this is still going on. When these regs started coming out, there's a lot of finger pointing of,
right,
gosh, the payers aren't updating their directories, and I submit my roster to them, and if only they updated my the directory based on my information in a timely fashion, then this wouldn't be an issue. And that is certainly an issue. That is certainly a problem. It's not happening as quickly as it should. However, the payers will come and say, well, gosh, the providers aren't sending the right information. And if only the providers would send the right information, then there wouldn't be any problem. How can I, as a payer, know where the provider is? The provider has to tell me. And so this debate, this conversation has been going on for years, ever since 2016, when the first wave of regulations started rolling out. And so there's plenty of responsibility to go around. I think there's, the payers are mostly being held accountable for this because CMS has purview and oversight over the payers. They're encouraging the payers to put requirements in their contracts with the providers to update their directories appropriately and incentivize them appropriately. But, we just discussed there is a provider workforce supply problem. So the payers can't enforce all that much. They need the providers in network, so they can only go so far as to coerce the providers to submit the right information. I think there's a couple of solutions that we could consider as an industry. And I think one is, on the provider side, being able to find the right repository of information to submit to the payers. Oftentimes they're going into their credentialing database, which is fine. It's a place to get it. But, some of these hospital systems and health systems, they've got pristine, complete data for their own directory that they're paying good money to clean up, and that patients are using to find doctors, and that data is complete. and accurate, at least relative to some of this payer directory. Like, wouldn't it be great to tap into that nice source of information to submit to the payer side? I think that would solve for a lot of these problems. And I think being able to introduce the right incentives for that to happen would help solve a lot of these problems.
Yeah, I agree. And it's amazing how many things are impacted by accurate or inaccurate provider data. And it has so many downstream ramifications when the data is wrong, and it just continues to build. It just snowballs. So we need to figure out that provider data accuracy. I'm going to move on to a very fun round, and this is our word association lightning round. So now in the famous phrase of every doctor, this is only going to hurt for a bit. I'm just teasing, it won't hurt at all. So I'm going to say a couple of words or a phrase, and this is speed association. So when I say the word, you tell me the first thing that pops into your mind. We'll do a test. This is a test. Harvard.
Zuckerberg.
Okay, good. And I just did that one as a softball because I know you went to MIT, so I knew there would be something coming, which is perfect. All right, so that's how it's going to go. I'm going to say a word or a phrase, and you tell me the first thing that pops into your head. Ready? Prior authorization.
Well, API. There's a new required API for prior authorization.
PBM.
High costs.
No Surprises Act.
Fiduciary responsible parties.
Interesting. All right, now I know you're also an avid reader, so the final question relates to both either reading, food, or dining. Completely unrelated. But if you could sit down with a person living or deceased in healthcare and have a meal with them or a drink with them, who is that person and what are you eating and drinking?
So I don't know if you know the name Eric Bricker.
Yeah.
He's part of A Healthcare Z, and he has this series of YouTube videos. I think there are literally hundreds of YouTube videos that he goes down the rabbit hole of these like nuanced and esoteric healthcare topics, and he's such a great explainer and educator. I've learned so much by watching those videos, and I almost feel like I'm giving away a competitive secret by mentioning his name. But I'd love to have a meal with him. Cabernet Sauvignon is fine. That would be great, and would just love to learn as much as possible within an hour's mealtime with him.
Well, I think that's a great compliment because when you fear that you're giving away potentially competitive information and it's about another individual, that's pretty high praise. And I think it's also interesting because as we talk about lessons from leaders, is that we never forget that we should be sponges to knowledge and certainly expose ourselves to as much knowledge as we can on this journey of healthcare and, in our personal and professional life. Any other thoughts, Ron, as we depart on some advice to someone starting out in healthcare and how to make it easier on them and how they could achieve their goals?
Yeah. Just piggybacking off of that, there's just a wealth of resources out there to tap into if either you're trying to get into the industry or if you want to reinforce some of the knowledge that you already have. Out of Pocket blog is great by Nikhil Krishnan. The Health Tech Nerd Slack is an amazing resource. And, I'm an open book. If you ever want to reach out to me, I'm happy to talk healthcare, tech, provider directory, interoperability. Love to engage with others in the industry.
Awesome. Totally agree. There's a lot of great resources out there. And if you love intractable long-term problems, healthcare has a home for you, I assure you. And if you need to get a hold of Ron, just look up Defacto Health and you can contact him through there. Ron, thank you. I can't say thank you enough. I appreciate your time this afternoon helping other folks learn about healthcare and a little bit more about what you do, and wishing you a very successful and pleasant rest of your day.